Hello, everybody. My name's Ed Pavlik, and I'm with my colleague.
Hi, Frank Lawton from London, UK.
This is another edition of GYN ONC Garage, where we look at papers in particular with regard to their nuances and with regard to their importance. Today, we're going to look at a paper that appeared in Cancer Epidemiology, and it is the risk of non-ovarian cancers in nationwide study of nearly 5,000 women in Denmark. Frank, what do you think about this paper?
Well, when I first saw it, I think many of us are aware of the links between epithelial ovarian tumors, the invasive epithelial tumors, and other cancers, often genetically associated with BRCA1 or BRCA2. And I have to say, I was not aware of any links between borderline tumors and subsequent development of other non-ovarian malignancies. So when I saw the title and the resume of this paper, I thought this is really quite interesting. Getting further into it, I think there's probably quite a few holes in it, and I'm not sure. I think it will engender a lot of research. I think that what the paper has shown is that there may be some links, but I think there's an awful lot of work to do, which may well, of course, keep epidemiologists and clinicians going for a few good papers. As you said, this is a Danish paper. They looked at 5,000 cases of borderline ovarian tumors, the two common ones, serous and mucinous, and then the rarer ones, and compared it with the incidence of subsequent malignancies in the general population. And in essence, they found that the serous tumors seemed to have an increased risk of developing melanomas, thyroid cancers, and myeloid leukemias, whilst the mucinous tumors seemed to have an increased incidence of lung, pancreas, and myeloid leukemias. There's some interesting data, I think, in this paper that makes me wonder very much about the results. And one of them is that the median age of these patients with borderline ovarian tumors was 50 to 53, which is a lot older than the median age for borderline ovarian tumors in all the other studies I've seen. Borderline tumors are for women, a third of them, I think, are under the age of about 30 or 35. So this was an old age range of women with borderline tumors. And I just wondered whether or not some of these were actually invasive tumors. The other problem is, of course, that because they're just comparing it with the general population and they're looking at it's a retrospective study, there are no data on other risk factors for the development of these tumors, BMI, smoking. There's nothing about stage, nothing about whether or not there are implants, whether or not these are invasive or non-invasive implants. We don't know how many of these women subsequently had a hysterectomy rather than just an oophorectomy or a cystectomy. We don't know whether or not some of these women who had removal of one of their ovaries might have had treatment for infertility. And we don't know whether if they had subsequent hormone replacement therapy. So there's a lot of real problems with looking at this data. The other thing that I am quite concerned about, and this may be my interpretation, but in the body of the paper, they say that, for instance, the incidence of thyroid cancers is 3% over the population, the general population. They say that this is a threefold increase. A 3% is not a threefold increase is 300%. And I don't want people to read this paper and think, good God, 300% increase. It's at 3%. And if you look at the incidence of melanoma worldwide, it's about 2 per 100,000. So a 3% increase or whatever it is not a huge number. I think from the point of view of follow-up, most patients, I thought, with the borderline ovarian tumor are probably discharged from care if there's no evidence of recurrence after possibly 5 or 10 years. And perhaps that should be longer. And perhaps it is important that clinicians should be looking for telltale signs of other problems. There's a lot of data here that needs to be corroborated, I think. And although it's quite interesting, I think there's a lot of data that really is not available and should be available if we're going to continue this thing forwards.
Sure. What caught my eye was they were exporting this information from national databases, And then it occurred to them that they needed to confirm the fact that these were either serous or mucinous borderline ovarian tumors. So I think they brought in Dr. Kerman
Yeah.
to take care of
Just
that.
check the histology, yes.
And so the 2,500 that they had gets whittled down to around 800 and change.
Yeah. Yeah.
But that's a good thing. I mean, to say we really want to make sure we're talking about what we say we're talking about. So I would say, they tried as hard as they could, but probably could not export the factors that you outlined just a moment ago. So, that means probably a prospective study or increasing the database for factors like exposure to sunlight for melanoma. Is there really a confounding factor there or a bias toward one group, or the other? I think, though, if I can read your mind, your interest was piqued by the fact that probably you feel when you find a borderline tumor, it's really good news for the patient. And, it's a matter of this is not going to kill them. We might have to do repeat surgery, but this is a whole lot better than serous ovarian cancer. So now we have a low malignant potential tumor that can be a harbinger of fairly deadly tumors, down the road.
Sure.
And so, how in good conscience, since it seems like a long time has been passed between the definition of the borderline tumor and when these other tumors come, how do you handle this? Certainly you can continue skin screening for melanoma, but you're really sort of getting into pretty invasive, pretty disruptive means of doing anything else, especially pancreatic and
thyroid.
So
yeah.
So that basically becomes a problem unless certain other markers, are involved. I think, though, conceptually, the concept should be recognized here that when something starts to go amiss at the cellular level in one spot, it probably can go amiss at another spot even more extensively.
Yes.
And that would be, maybe our interpretation of what this would mean and why there should be more research in it. That's really what I feel about this. I agree, really with you. I was very pleased to see that they had 2,500 roughly people in each group. And it would be very, very easy to have less than that. And even when they whittled it down to 800 and change, that's still a good number. So,
I mean, what they say, and quite rightly, is that there are presumably shared risk and genetic factors for the subsequent development of these tumors. And it's interesting, I couldn't find any data for the incidence of melanoma in Denmark, but as most of us know, the incidence of melanoma in worldwide is highest in Australia and New Zealand. But then interestingly, and I didn't realize that, Norway is third and Sweden is fifth.
Wow,
so it could well be that the risk of melanoma is something else to do with might be exposure to sunlight, for instance. It's interesting, isn't it, that numbers 3 and number 5 in the world are right next door to Denmark. Anyway, I think, as we both said, I think the paper is very interesting. It's going to require a lot more work, but it'll keep epidemiologists and people in business for quite a while, I would have thought, before we've got a definitive answer here.
Absolutely. Well, I think we can put this paper to bed.
I think so.
And we'll appear again the next month with another edition of GYN ONC Garage. Frank, it's good to see you.
Take care, my friend. Bye-bye now.
Bye-bye.